Because we have, as you can tell, a wealth of speakers today, and really about an hour and a half to 2 hours. I'm going to get started just with very brief introductions, but I want to begin even before that by saying thank you to you all for coming today. I know that it is a particularly busy time of the semester with a number of competing events, and we're delighted to see you here. So I just want to say that today we are actually in collaboration with the Pardee Center at Boston University, thanks to Joe Harris. And we have here on the screen a kind of larger set of events around global health that are open to the public and are also streamed via Zoom. And so for any of you who have interest in kind of pursuing some of the thoughts or references, but also just kind of, attending more talks around the politics of global health, this would be, I think, an excellent resource. So today we are really spoiled by having 5 incredible speakers who represent different disciplines: sociology, political science, also methods, ethnographic methods, comparative historical analysis, statistical, large N methods, and looking at a range of different diseases and dimensions of public health in many different parts of the world. And you'll get a sense of the range of the work and also the quality of it as our speakers get started today. And so I'm going to keep introductions extremely short, and also to let you know that, we could spend a month with these speakers, a week, at least a whole day, asking them each to kind of give us long presentations. So I hope you'll think of this as really a flavor, kind of giving you a tasting of some new perspectives, new exciting perspectives on global health, but also an entryway into each of these scholars' research, which is literally like we're just giving you the absolute lightest taste of it. So each speaker will go for between 10 to 15 minutes, and we'll have hopefully still plenty of time for discussion afterwards. And we will go in, our poster is actually a constellation, so I was trying to come up with a list, but we'll start with Siri. Did I pronounce your name right?
Sue.
Sue, perfect.
Close.
Someone who has my name regularly mispronounced.
I understand. I get it.
Sensitive to that. So Siri is a professor of sociology at Brandeis University and has worked on questions of reproductive health. Has a book coming out called Dying to Count.
Oh, it was published,
Has it been
2021.
published?
Yep.
Oh, congratulations.
Thank you.
That's excellent. And will be speaking to us first. Second, we have Professor Kevin Croke, who is at this Harvard School of Public Health, and again has a wealth of exciting material, and is got an exciting new book on primary health care across the world, but focusing in particular on Africa. Third, we have Professor Rosemary Taylor, who comes to us from Tufts and has worked on everything, classic work on new institutionalism, but also critically on disease identities across the world, but also especially in Europe. Number 4, we have Professor Joe Harris, who has worked on things like universal health coverage, the role of bureaucrats and other kinds of health personnel, particularly in East Asia and Thailand. And we'll conclude with Gowri Vijayakumar, who works on the same part of the world as I do in India, and in particular on questions of sexual health and HIV. And so please join me in just giving a round of applause to this incredible panel, and we look forward to each of your presentations.
All right, good afternoon, everybody. Thank you for coming during your lunch times. Thank you to the Watson Center and to the Pardee Center at BU for hosting. My current project explores how misoprostol is transforming the technological, political, clinical, and professional landscape of reproduction in Burkina Faso and Senegal. Now, as many of you probably know, misoprostol is a uterotonic medication that softens the cervix and causes the uterus to contract. This medication was first released on the global market in the mid-1980s under the brand name Cytotec by Searle, which is now under Pfizer, for the treatment of gastric ulcers. Since the late 1990s, misoprostol's effectiveness for off-label indications such as first trimester abortion, post-abortion care, and the prevention and treatment of postpartum hemorrhage has been documented in many studies around the world. And since Pfizer's patent on misoprostol ended in 2000, it has been manufactured by pharmaceutical companies around the world and is available under a variety of brand names around the world. So I've shared some photos of misoprostol in Senegal. The image in the middle was taken at a private pharmacy where two brands of misoprostol, Misoclear and Misodia, both manufactured in pharmaceutical companies in India, are in stock. And the image on the right was taken in the maternity ward of a public hospital. And before I go any further, I want to acknowledge my fantastic partners on this project, Dr. Tidjane Ndoye, who's a sociologist from l'Université Cheikh Anta Diop in Senegal, and Dr. Nathalie Sawadogo, who is a demographer from l'Université Joseph Kizerbo in Burkina Faso. So in December 2022, the World Health Organization announced that in the past decade, Africa's progress against maternal mortality had flatlined, and that it will need to reduce maternal deaths by a massive 86% to reach the Sustainable Development Goal, the Sustainable Development Goals by 2030. Hemorrhage is a leading cause of maternal death in Africa, whether related to labor or unsafe abortion. And while skilled attendance during delivery has increased throughout Africa, quality of care remains a significant problem. So misoprostol has been lauded by global reproductive health experts as a pharmaceutical solution to the persistent problem of maternal mortality in developing countries. It is relatively inexpensive in small quantities, it's amenable to self-use or administration by non-physicians, and it's heat stable. It does not require a cold chain. Misoprostol holds particular promise for improving women's access to reproductive health care in sub-Saharan Africa, where nearly 62% of global abortion deaths occur, where hemorrhage accounts for at least 25% of maternal death, and where there are only 2.2 health workers per 1,000 population. And so the World Health Organization, starting in the mid-2000s, began to incorporate misoprostol onto its list of essential medications for various obstetric indications, including induced abortion, post-abortion care, and preventing and treating postpartum hemorrhage. So our research takes up the story of misoprostol in Francophone Africa, where NGOs have been conducting clinical research on misoprostol for post-abortion care and postpartum hemorrhage since the mid-2000s. Now, some of this research on misoprostol for approved obstetric indications has been funded by donors like USAID and the Gates Foundation that typically do not support abortion-related activities. Throughout the region, ministries of health have integrated misoprostol for approved obstetric indications into national lists of essential medications and onto national pharmaceutical supply systems with multiple brands registered across the region. A handful of ethnographic studies suggest that misoprostol use for abortion is common in urban areas, and women obtain misoprostol with or without a prescription from formal and informal health workers, as well as from friends, relatives, and partners. However, these studies also show that access to misoprostol requires significant social capital, and that low-income women are most likely to be exploited financially and sometimes sexually by vendors and brokers of abortion services. There have also been important shifts in the political landscape of abortion. So in 2021, the Organisation pour le dialogue pour l'avortement sécurisé, Organization for Safe Abortion Dialogue, was launched. It's really the first of its kind in the region to openly engage with safe abortion. And so this is a regional network that supports advocacy, funding, or fundraising, research, health systems strengthening, as well as work around commodity securities. Also in 2021, the country of Benin decriminalized abortion under most circumstances. So in popular and global public health literature, and in conversation with some of our interlocutors who are safe abortion advocates or who fund abortion-related activities or programs, misoprostol is often described as a pharmaceutical solution or a silver bullet, a magic bullet to the problem of maternal mortality related to obstetric hemorrhage, but mostly from unsafe abortion. It's framed as a revolutionary, transformative, transgressive, and even feminist intervention. Right? Medications like misoprostol transform and transgress the meanings and practices related to abortion because they remove abortion from medico-legal systems and place them into women's hands. Right? This is precisely where we got the name of our project, into women's hands. The private sector is framed as a vital part of this process, right? A site where consumers can discreetly obtain medication to self-manage abortions. Most of what we know about misoprostol in Burkina Faso and Senegal comes from statistical studies of availability in private pharmacies, so brick and mortar pharmacies, and public hospitals. And it should be noted that most of these studies are funded and co-conducted by NGOs and donors that are headquartered in the global north. Despite these developments, little is known about the circumstances under which misoprostol is purchased, sold, distributed, and used by consumers and health workers in the private and public sectors of the health system and by nonprofit organizations. And so our study aims to move beyond popular narratives of misoprostol's life-saving potential and narrow statistical estimates of misoprostol's availability to illuminate multiple pathways through which misoprostol is available to some women, health workers and health facilities, and not others. And not only for self-managed abortion, but for obstetric care more generally. Now, while misoprostol often tends to be framed as a newish reproductive health technology in the region, we insist on situating misoprostol in a much longer history and politics of reproduction in the region, including the role of the USAID with restrictions around abortion services and technologies, such as the Mexico City policy and the Helms Amendment. Starting in the early 2000s until around 2020, there has been a huge debate at the level of the World Health Organization in terms of whether there is sufficient evidence that misoprostol is as effective as the current gold standard for managing postpartum hemorrhage, which is oxytocin and which requires a cold chain. There is evidence from Uganda that the introduction of misoprostol by NGOs led to parallel health systems or parallel forms of, and unequal forms of healthcare, right, between the private and public sectors. And finally, we also recognize misoprostol's capacity as an abortifacient within a much longer history of population control in the region of Francophone Africa, which has some of the world's highest rates of fertility, where since the 2000s, fertility in this region has been conceptualized as a vector for climate change, for transnational migration, and for Islamic fundamentalism. In 2019, for example, a Finnish parliamentarian suggested mass abortions for women in Africa as a solution to the climate crisis. So, with all this in mind, our study explores the distribution, procurement, circulation, availability, quantification, and use of misoprostol by consumers, pharmaceutical vendors, health workers, health authorities, donors, and NGOs in Burkina Faso and Senegal. And we use a comparative, multi-sided approach to illuminate how the local context intersects with regional and global policies to shape the availability, use, supply, and distribution of misoprostol for approved and unapproved obstetric indications in these countries. So through this approach, we aim to examine, right, the complex geopolitical and health systems and professional processes involved in approving and registering the drug, determining who can administer it, and in making it available and affordable to women. In Senegal, for example, a study in 2021 found that the average cost of post-abortion care using misoprostol in public hospitals was $62, right, which was not much lower in cost than surgical services, right, for post-abortion care. So, we're asking, who decides what kinds of obstetric care should be available and where to Burkinabe and Senegalese women? To what extent does the promotion of misoprostol in the private sector by international NGOs generate parallel and unequal systems of obstetric care? How do these activities benefit or disadvantage various kinds of health workers, including physicians, nurses, midwives, pharmacists, and traditional birth attendants, right, or other kinds of community health workers in urban, rural, private, and public sectors of the health system? To what extent does the availability of misoprostol in formal and informal pharmaceutical markets contribute to improved reproductive health outcomes among women, and in particular, young, low-income, and rural women? So ultimately, we hope with this project and our data to inform policies and protocols related to clinical care, procurement and prescription of misoprostol, and use of misoprostol by health workers and women. And drawing on principles of reproductive justice, we aim to yield information that contributes, right, to improved obstetric care and reduced maternal mortality through health systems strengthening. So just a few minutes about our methodology. Our research takes place through a collaboration between 3 universities, and every aspect of this research is collaborative, including the development of our research design, the development of our data collection instruments, and data analysis, or data collection and analysis, and the write-up of results. Our work is funded by the Hewlett Foundation. We received a first round of funding in 2022, and we just received additional funding for until 2025. So we take an explicitly decolonial approach to knowledge production about reproduction that centers African universities in conducting research with the potential to influence policies that in turn affect Africans and African women and health workers in particular. My colleagues' universities receive the bulk of our funding because they are primarily involved in conducting and managing the field work that is conducted by our research assistants, who are graduate students at these institutions. And by training and mentoring and supervising young graduate students at national universities, we aim to contribute to a future generation of African researchers equipped with skills in ethnography at a time when statistical methods are often what's most valued in the field of public health. So our project aims not only to investigate structural inequalities in how misoprostol is used and distributed, but also to address structural inequalities in the production of knowledge about misoprostol and obstetric care more generally. So I've listed some of our data collection methods, including in-depth interviews, observation. We just received IRB approval to do mystery client studies. I could speak for another hour about the many methodological and epistemological challenges we've experienced. I will just end after I note that the most significant challenges we've been experienced have been from my institution at Brandeis University in terms of structuring equitable contracts that determine equitable flows and directions of resources. Somehow, inexplicably, Mexico City policy language showed up on our contracts. Earlier this year, when we were renewing them, our funder is not the USAID government, is not the U.S. Agency for International Development, and the Mexico City policy is not active under the Biden administration, right? So this is just an example of some of the problems that can come up when doing this kind of research. So I will stop here and look forward to the Q&A. Thank you.
Set myself a timer so I make sure not to overshoot. And there we go. Thank you everyone for coming, and it's very much a pleasure to be here. And thank you to Prerna and Joe for hosting and facilitating the workshop. My name is Kevin Croke. I'm an assistant professor at the Harvard School of Public Health, and I work on the topic that I'll talk about today, which is the politics of primary health care. And I also have a research interest in also the impact of primary healthcare programs. So I work on the politics of health, but also, as we'll talk about in the discussion, some of the programs themselves and their impact on health and health outcomes. But one thing that I'm particularly interested in studying in this project, and I should say this is a preliminary project. Prerna very kindly said that this is a book. It aspires to be a book. So it's a set of case studies which have been completed but which have not been fully synthesized. And so I'm really eager and interested to hear all of your feedback today. But the topic is primary health care. So this has been a global aspiration at least since a famous conference in 1978 called the Alma-Ata Conference. And the idea here was that, just as we overemphasize complicated and expensive medical care in the U.S., many low-income countries at this period in the late 1970s were spending the vast majority of their health budgets on curative care and on hospitals, when the vast majority of health problems, and especially infectious disease and maternal and health challenges, were things that could be addressed or prevented with primary health care, often delivered in rural areas by doctors, or more often by nurses or even community health workers. WHO still energetically promotes primary health care, and yet gaps across the world are vast. And the WHO currently estimates that we're failing to save 60 million lives that could be saved if primary health care was adequately scaled up by 2030. And my interest is in the political factors. So there are financial factors, there are technical factors, but in the previous period, the period after this Alma-Ata conference, when many countries were inspired and attempted to take their primary health care programs to scale, many of them foundered in the decade or more after the Alma-Ata conference. And many of the retrospective analyses of these programs pointed to political factors. These were often public health or global health researchers who were analyzing their own programs, and they came to political diagnoses. But we, as political scientists, I think have not studied this in as much detail, and we can see some of the political challenges that come out of these public health case studies. Distributional conflict between urban and rural areas, between classes, even between doctors and lower medical cadres. But also ideology. Should public health and primary health care dominate health budgets, or should there be a larger role for the private sector or for curative care, as well as state capacity gaps and inadequate financing, which is always a challenge. So I want to consider the challenges today and how they can be overcome, the political challenges specifically, and I'd like to do that through 3 case studies of very important countries across Africa. These are all places in which, with my other hat, with my public health hat, I've been working on interventions and program evaluations. And as I have worked on those research projects, I have really come up against many of the challenges that were highlighted in this earlier literature, reflecting on the political challenges to PHC. But I have also seen a number of countries and regions that have made, I think, dramatic progress and have overcome some of those political challenges. And so I thought these 3 case studies would be a fascinating way of looking at this variation in success or less success across PhD expansion. So the first case is Ethiopia, which many people in health may be familiar with. Expanded primary health care in a very dramatic way over a 20-year period. Unfortunately, with the emergence of conflict in 2019, that progress has stalled. But it was the current Director General of the WHO, or Secretary General, was the architect of this primary health care expansion. The second is a series of policies in Nigeria. One is called the Saving 1 Million Lives program. The other was the National Health Act, which was passed in 2014. And the third case is a major health system reform in Kenya, which directly affected primary health care, which was their health decentralization, which followed from a constitutional reform in 2010. So each of these case studies, I think, takes the challenges which were identified in an earlier generation of study of primary health care programs and the political challenges, and it tries to look at how these countries, their ministries of health and other health reformers have tried to surmount these political challenges. And so I'll highlight both areas in which they have surmounted those challenges and areas in which they have run up against persistent difficulties. Each of these cases is very rich and complex, and as other speakers have said, could take up a whole day, a whole week, a whole seminar. But I'll give a brief outline and then just try to draw a few of the commonalities in the time I have left. Ethiopia, under its former government, the EPRDF, it really saw health as a key element of a broader developmental state project. And so it recruited somewhere between 20 and 30,000 health extension workers and deployed them to their lowest administrative level and made them fully paid members of the civil service and made them a professional part of the health workforce. Beyond that, they instituted something called the Health Development Army, in which there was one volunteer health extension worker for every 5 households. So a massive mobilization of society. In this way, primary health care was really linked to a political mobilization project. This led to unusually strong implementation of primary health care, and it was something that was at the top of not only the Minister of Health speeches in many cases, but also the Prime Minister of the time. And I'll show you in a moment how effectively this translated into implementation. But it also made the project vulnerable to political backlash, which occurred starting in 2019 and 2020 when civil conflict broke out. But first, just a picture. This is the distribution of public health facilities in Ethiopia in 2003. It's a country of over 80 million people. This is not a huge amount of health facilities for that population. After this commitment to primary health care had been put into practice, the picture looks very, I would say, dramatically different. So this is 10 years of investment in primary health care, transformation of population coverage. On the other hand, as my interviewees pointed out, the fact that this was linked to a broader political project, added vulnerability to the project and made it vulnerable to the backlashes that ultimately occurred. And so, in a moment, I'll contrast this to a different way of approaching primary health care. In Nigeria, you had at the top of the Ministry of Health around the same period, equally, I would say, dedicated reformers who had innovative ideas, and they put in motion something called the Saving 1 Million Lives project, which directly targeted primary health care and maternal and child health, but also a broader systemic reform called the National Health Act, which tried to enshrine in law that 1% of the Consolidated Revenue Fund, which is essentially where oil revenues accrue in Ethiopia, would have to be directed not just to health, but directly to primary health care. It would have to be transferred directly into primary health care facility budgets. So I think, like the Ethiopian case, you had innovative reformers at the top of the ministry who were really trying to solve operational challenges and financial challenges of primary health care, taking resources and directing them to PHC. But one thing that has come through in my interviews around this project is that, unlike Ethiopia, this was a Ministry of Health, or even a group within the Ministry of Health's project. It was not linked to a broader political project or mobilization. And so when the health reformers bumped up against a feature of the way political power is distributed in the country, they were unable to overcome that. So a key feature of the constitution in that country is that the Ministry of Health is only responsible for tertiary health care, so specialized hospital care. Secondary care is under the responsibility of state governors. Primary care is under the responsibility of local government authorities. And the Constitution gives primary health care budgets to governors, and the Ministry of Health has little to no control over that. And there are limited to no mechanisms of accountability for these health budgets at state level. And so Ministry of Health people were very aware of this. They realized that the higher political levels would have to address this gap in accountability, but presidents in this period were unwilling or possibly unable to challenge this sort of fundamental constitutional bargain about whether governors or central ministry had control over primary health care. And so we see similar, I would say, program design, but a different sort of underlying distribution of political power, which stymied, in this case, a primary health care project. And as one interviewee said to me, the governors are kings. You can use what he called soft power. You can explain your goals. You can invite them to workshops. You can try to incentivize them. But ultimately, they're in the health sector. They're kings, and you, as the Minister of Health, have much less power than everybody outside the country perhaps believes that you do. In my remaining moment or two, I will just say the case of Kenya, which is a much less fully realized case study so far, is one in which I see both interesting parallels to the Nigerian case, but also striking differences. So the constitutional reform in 2010 decentralized health services to the county level. So as in Nigeria, where, as we saw before, the governors are kings, in Kenya, after 2010, governors control primary health care services. The Ministry of Health, again, has a responsibility for higher level services and for policy and other functions. So the Ministry of Health has much less power than it used to, but at least in some counties in Kenya, there's interesting evidence of developmental coalitions emerging for health at the county level. A research group that I've been part of in collaboration with Gowri Wellcome Trust has been studying this in Kakamega County in western Kenya for the last 2 years. And we've been observing a very dynamic and in many ways positive process of competitive politics at the county level that is focused on, in many ways, on health, because it's one of only 3 of the services that governors control. And so this is in Kakamega. The outgoing governor, he built a hospital in his home sub-county. This is a place called Butere. It was a place where there already was a hospital, and you might think this was maybe not the health maximizing step to take. On the other hand, it's also a hospital that's needed, and this is something that might look like what political scientists would call clientelism. You're directing resources to your home area. There's an element of responsiveness there, but also maybe inefficiency. But on the other hand, we also see a very interesting dynamic where governors are also mobilizing, publicizing, and credit claiming around service delivery. And so the current governor is very active on all communication platforms around trying to address shortages of drugs, in this case in a different hospital, a place called Malava. He's even gone to, this is just from a few days ago, he's even been mobilizing a sort of coalition of officials to try to solve drug shortages, and even accusing his own officials of stealing drugs from hospitals and taking credit for solving these problems and improving services at the county level. And so one question we're very interested in is trying to understand why in some counties is there a kind of new politics of health emerging in which governors see themselves as accountable and try to take credit for positive developments, where in other places these coalitions seem to be more nascent or having trouble getting off the ground. And since I know I'm out of time, I'll just mention that this is in many ways based on work which was not explicitly political, which was more about health programs, but in which I've learned quite a bit about the politics of health with collaborators at EDRI in Ethiopia, Nigerian co-authors, and then the Gowri Wellcome Trust team, and also my Harvard colleagues in Kenya. So thank you very much.
think you want this. I could read it again.
Yeah.
Okay. So, thank you very much, Prerna, for the introduction, and to you and Joe for the invitation to come to Brown, and to the Watson Institute for hosting this event. It's a great pleasure to be able to talk to this group who are interested in issues of global health. Let me give you a little background. For the last decade, I've been looking at how societies and their governments deal with risk, in particular health risks, and especially those that are perceived, correctly or not, to come from beyond their borders. And the book I'm writing now is a comparative historical analysis of two viruses, HIV and hepatitis C, from the moment of their identification in 1984 and 1989 to the development of drugs to manage one, HIV/AIDS, in the mid-1990s, and actually cure the other, hepatitis C, in the mid-2000s. And in this work, I build on some of my previous work on what I call disease identities. And I explore first how each of these viruses were discovered, acquiring a clinical and scientific identity, and second, how policy responded to them as they acquired a political identity, and third, how compensation was or was not granted to those infected when HIV and HCV got into the blood supply, based on a legal identity, and finally, how the drugs used to treat them were sold on the basis of a commercial identity. So that's kind of the background. But today, I want to talk about the issue of compensation. And my focus is on one case, because it's very difficult to generalize about the processes of compensation. As you probably know, during the 1980s, thousands of people receiving blood products or blood transfusions were infected with either or both of these viruses. So the main empirical question I'm posing is, how did the British government decide whom to compensate for the harm they suffered from contamination of the blood supply, and by how much to compensate them? And we can see this as a case study of a larger question, namely, how do governments compensate their citizens for irreparable harm they may suffer amid disasters, particularly in cases where governments bear some responsibility for those injuries? How do they do compensation? And now it's hard to generalize about this, as I said, because at the moment, compensation is a pressing issue in all sorts of dimensions. At the broadest level, people are asking for compensation or reparations for historical injuries and wrongs. And then there are a series of natural disasters, a lot of them brought on by climate change, which is wreaking damage across the world. And last week, we've witnessed significant flooding in New York. California appears to be on fire for ever longer periods during the year, and recently we witnessed the catastrophic fire in Maui. And so, but these natural disasters, then, in terms of how people are compensated for them, are different from those where public authorities are seen as bearing some responsibility for them. And then finally, there's quite a difference between whether governments feeling or being pressed into compensate. How is that done? Is it through a legal route? Is it done through a compensation fund? How else? Okay. So, turning back to the British case, there are several puzzling aspects to it. In Britain, compensation was granted seriatim to distinct groups through a process that advantaged some people infected with NHS blood relative to others. And the groups given compensation changed over time in a process that extended over a period of 35 years and is not yet finished. I mean, as you'll probably know, in the United States, people put that behind, this whole issue behind them, when they passed they passed a compensation to hemophiliacs with HIV, but that was about 20 years ago. And Britain is currently having a third major public inquiry as we speak, which is shortly to report. So payments were initially made to people with hemophilia and HIV, to those with HIV but not hemophilia, and then to certain people with hepatitis C. And one of the puzzles is this: why was financial support made available to narrowly circumscribed groups in this particular succession? Now, this is a very long story, so I'm going to focus now only on the first group to receive any financial redress, namely hemophiliacs who were infected with HIV through their treatment with blood products. And I'm also going to use this case to make a theoretical argument with wider resonance about how governments operate, and in particular, about how the categories that are at the heart of governance are constructed and sometimes enshrined in policies. Oh yes, I was saying also Fukushima, that's one of the major natural catastrophes followed by a catastrophe that some people thought the government should have handled better. So the theoretical argument, which I'm going to say a little bit about, is that the key point is that the process of assigning compensation for those infected by the blood supply was ultimately a process of categorization. It entailed drawing sharp distinctions between those who would receive payments and those who would not, and then establishing the worth or the value of their suffering. And categorization is a fundamental feature of governance. In his account of the myriad ways in which states see, James Scott has noted that in order to make their worlds legible and thereby governable, governments end up codifying everything from land to people. But how are these categories constructed? And why do they take on a particular shape? These are the questions I'm going to cover very briefly today. And to do so, I'm going to take several theoretical steps. And more, I just have time to sort of lay out this theoretical approach, which I'm interested in any feedback you may have. Because policymaking involves the construction of categories, it's always to some extent, of course, a cultural process. And it's been approached as such by a number of influential scholars. And first, I want to suggest that the prevailing views of the role of culture within this process are generally too crude. Explanations for how nations make policies and manage uncertainty, they often reflect an important school of thought that foregrounds political culture or a national regulatory style. I mean, a lot of the literature on Fukushima, for example, said, well, of course, compensation was done the way that the Japanese do it. They do it this way because they're Japanese, right? Meaning they have a certain cultural approach to this. And I argue that the concept of a national policy style or political culture is too blunt an instrument to capture how political decision-making proceeds. And in particular, these approaches tend to miss the dynamism involved in policymaking and in the concomitant process of categorization. To borrow Bill Sewell's insightful formulation, public policymaking is an intrinsically eventful process whose very eventfulness affects the character of the outcomes. So I argue that in order to understand who was compensated when and by how much in Britain, we need to recognize that the categories central to these outcomes emerged from a dynamic process of cultural negotiation that took place consecutively and sometimes simultaneously in several different institutional arenas. And I focus on the public political arena, the realm of the civil service, the voluntary sector of civil society, and the legal arena. Well, obviously, I do not have time to talk to you about all this. So the second theoretical move I make is to argue that in each of these spheres, debate about the relevant categories was not predetermined by a national policy style or culture, but turned instead on distinctive features of these institutional arenas. That's to say, the relevant categories were inflected by what I'm going to call the institutional logic of each arena. So the questions here are, what are these institutional logics and how do they work? Now, as some of you will know, the concept of institutional logics has a very long history, but much of this literature is curiously unclear about a key issue. What is the nature of the relationship between institutions and their logics, And in particular, why do certain kinds of institutions give rise to certain kinds of logics? And I'm not going to go into detail about this literature, but on the one side, there are some minimalist formulations in which these logics are said to be institutional, mainly because they can be found in social fields where specific kinds of institutions operate. And on the other side are maximalist formulations in which the cultural systems constitutive of these logics are giving such a superordinate status that they become responsible for creating the institutions themselves. In my view, the first approach doesn't say enough about why these logics are institutional, and the second assigns so much force to cultural logics that they become synonymous with irrelevant institutions, making it impossible to ask, why do certain kinds of institutional arenas give rise to certain kinds of cultural logics? So I'm using this British case to develop some more precise formulations about how institutional logics are generated and come to bear on the outcomes that emerge from each institutional arena. Now, I do not have time to lay out more about my theoretical perspective, so I'm just going to skip over it really quickly and turn to the British case again and just talk about one institutional arena in order to illustrate what I'm trying to talk about institutions and the relationship with their logics. So because contaminated blood and blood products were provided to haemophiliacs and others by the National Health Service in Britain, it was to the government that the injured and their families turned for compensation. Of course, to those who suffered from infection, compensation meant a lot more than financial redress. For the past 35 years, they've asked not only for financial support, but also for justice, which meant holding the government and others to account. They wanted an apology, and they wanted the punishment of the guilty. And this has not happened. What the injured received instead was money. And the process whereby they received it was protracted and in some ways peculiar. And I can't go into all the features of this process. Instead, I'm going to turn to the first institutional arena where people tried to make the case for compensation. And that is the parliamentary and public arena, where what was at issue was the basic decision to provide some kind of compensation. And three features of the outcomes that emerged from this arena are notable. First, this arena was initially the site of protracted resistance by the government for all claims for compensation. However, second, it became the arena in which pressure for compensation was felt most intensely and eventually succeeded. And third, the shape of this arena had much to do with the fact that the first, and for a very long time, the only group to be compensated was haemophiliacs. And haemophiliacs who had not both viruses, but only one, HIV. The Conservative government under Margaret Thatcher first faced claims for compensation when contamination of the blood supply.
It's currently clear and 72 degrees.
Sorry. Yes, I was trying to time myself, but that misfired. The Conservative government under Margaret Thatcher first faced claims when contamination of the blood supply was revealed in the mid-1980s. And the initial reaction of the government was negative. In 1985, Kenneth Clarke, then Minister for State, rejected these claims, declaring that there has never been a general state scheme to compensate those who suffer the unavoidable adverse effects which can unhappily result from many medical procedures. And he could hold the line in this fashion because he knew that the chances of people winning compensation through the legal system in Britain was very slim. I mean, in some countries, that's what happens. But in Britain, affected families had to prove negligence, which is a branch of tort law. And negligence requires a very high standard of proof. Claimants had to show that the risk that led to injury was foreseeable and unreasonable, a difficult task in its own right, and especially in an era of modern manufacturing processes about which most claimants have no knowledge or access to information. So as late as 1987, then Secretary of State for Health and Social Services, John Moore, argued against providing compensation to haemophiliacs on several grounds, but most important on the grounds that it would set a precedent. In many ways, we'll see, or we will not see in this talk actually, that the arguments came directly from the Treasury, from the civil service. But then the institutional logic of the public political realm began to affect both the kinds of categories that became central to discussion of the issue and the eventual outcomes. As everyone here probably knows, the institutional setting for British democracy means that one of the principal objectives of any government is to retain the support of a wider public so as to win elections. And here, as in most democracies, the institutional of that logic of that arena is such that the most powerful political appeals within it often turn on the issues of fairness. So the issue of compensation was soon debated in the British political arena in terms of categories that emphasized deservingness and issues of innocence and suffering, moral categories that did not have much influence in other arenas but engaged powerful cultural schemas at the heart of British politics. So we find that in parliamentary debates about compensation, British MPs invariably adopted a discourse of innocence, special circumstances, finitude, and stigma. A story that appeared in The Guardian in describing the social ostracism on the playground is typical of the relevant discourse, as you can see in this quote. And the message in this and similar articles is unmistakable. The playground is a site of innocence. What hemophiliacs are experiencing is unfair. And we can see the institutional logic at work here, an issue that was debated inside official circumstances, largely in the pragmatic terms of cost-benefit analysis, acquired a different character in this public arena. What policymakers initially wanted to see as administrative categories were translated into moral categories, turning on guilt and innocence, and above all, moral deservingness. It's a long story, but faced with these kinds of appeals, which carry particular power and resonance in the political arena, the government finally gave in, but only for the case of hemophiliacs. In November 1987, the Minister of State for Health wrote to his colleagues, and less than 2 weeks later, the government announced that it would make a payment of £10 million, pounds, but only to hemophiliacs infected with the AIDS virus. But as he struggled to describe why only this group should get it, it was not lost on the civil service that some of the criteria that were cited for the award opened the government to claims from other groups. And it was concerns such as these that dominated the rather different discussion that took place within these other institutional arenas that unfortunately I do not have time to lay out for you. But I'm just going to say, yes. And this is, as I said, an ongoing story. This is, those of you who are interested can keep their eye on a report that is supposed to be issued this month, and we'll see what the eventual outcome is. Okay, thank you very much.
All right. So first, okay. All right. Okay, great. So first, thanks to Prerna and Hayden, the Watson Institute, for hosting us, and the Party Center for their sustained support. It's a great pleasure to be here with you all and share this work with two former graduate students that's currently a work in progress. So this talk centers on what we call health technology assessment. We can think of that in most basic terms as a kind of cost-benefit methodology that's grounded in economic analysis. Safety and efficacy are two important concerns of this methodological approach. It's brought to bear in use on determining the sort of cost effectiveness of things like medical devices, pharmaceutical therapeutics, and it can be organized in a variety of ways. Individual people can use HTA to do analysis on the sort of cost effectiveness of different drugs, for example. It can be institutionalized in state agencies or nonprofit organizations, or professors can be taken up by the state to do consulting projects on different products that the state might be interested in understanding more about. It can be required as part of state statutory processes aimed at sort of understanding whether a drug should be included in a benefit package for a state health insurance program, or just simply an advisory opinion. But it's an important tool for cost-effective priority setting, particularly in resource-constrained environments. We live in a world where universal health coverage has become very important, and so increasingly in resource-constrained environments, this is thought of as an important tool to help countries get there. And so given that HTA is not a new field, and the resource scarcity and need for priority setting and efficient resource allocation in the health sector is so important, why is HTA institutionalization a relatively recent phenomenon in the industrializing world? Why hasn't diffusion followed a more uniform pattern across regions? What accounts for what I see as fragmented regionalism with greater levels of HTA agency development in Latin America and Asia and relatively lower levels in Africa? This is work that's based on archival research at the WHO and also approximately 25 interviews with global HTA experts. This is a relatively small field, right? So 25 interviews may not sound like much, but in fact, in that small rarefied space, it covers quite a lot of the field. We can think back about Ken Arrow's paper, Uncertainty and Welfare Economics of Medical Care, in 1963 as sort of kicking off a lot of what many consider the field of health economics. It was not long after that that the field of HTA was born. The U.S., of all places, was the first country in the world to have an Office of Technology Assessment in 1974. That is ironic because we don't allocate resources particularly efficiently in this country. As far as healthcare goes, we spend about 20% of our economy on health spending. But the implementation of the U.S. OTA office, which was subsequently closed in the 90s, spread to other countries, notably Canada, Sweden, Spain. They all became early adopters of HTA, started their own agencies, and began also helping to this methodology to spread internationally. There were different journals and professional associations that began to form. You see some there. The first international conference on HTA was in Stockholm in '79, and Sweden established the first national HTA agency in Europe in 1987. There's some more of the professional associations related to that in the early 90s. And so there's a great paper by Olga Leblova that shows different waves of HTA adoption in Europe. We see one wave over about 13 years that is happening between 1987 and 1999. About 5 years later, they have another set of wave there, and then some non-adopters. It wasn't until 2006, though, that the regional HTA body formed called EUNet HTA. Now, that's quite interesting and sets the stage for us to look at other regions of the world and patterns there. And even though this doesn't show up very well, I'll give you sort of some broad brush strokes about other regions of the world. You do have different countries in Asia, like Malaysia, Taiwan, South Korea, Thailand, that have relatively long histories of HTA use, and in some cases institutionalization of agencies. Some regional bodies that have helped to further catalyze interest in HTA, and also a recent flurry of interest in that area. In Latin America, a similar kind of story. Some regional leaders like Chile, Brazil, Mexico, Argentina, Colombia, a new network of agencies starting around 2011, again after the European one in 2006, and other regional developments. In Africa, some important work being done in South Africa that's aimed at helping to catalyze greater interest and institutionalization of these methodologies there in the region, but relatively low levels of institutionalization. And if we look at other social innovations, to put this in focus, we can think about the field of conditional cash transfers. Also economic focused, right? Also about helping improve people's lives broadly. But what's interesting there in work by people like Moraes da Silva e Silva, we see relatively rapid spread of CCTs around the world, driven by the World Bank in large part. James Ferguson calls this a new emerging form of welfare provision around the world. And what's interesting, I think, in drawing that contrast is we see the relative absence of the World Bank and the WHO as players in the field of HTA in a relatively critical period, right? After the OTA is founded in 1974 up through the 90s. Why is this interesting? Well, this is interesting because one, the World Bank is relatively influential and growing so in the 1980s in the field of health. It is the largest health funder. It's the largest funder in the field of global health today, dominated by economists. And in the 1993 World Development Report, Qualities and Dailies was really the centerpiece, right? And at the WHO, what's interesting is the interest in HTA grew out of a WHO regional office, the one in Europe in Copenhagen, that had a program on appropriate healthcare technology. And it steadily fell under the influence of the World Bank's more technocratic approach, right? We see leading scholars mention how the architects of the 93 WDR moved from the World Bank to Geneva over time. And they began to build in the 2000s more sort of economic focused projects. But it's really interesting because the development within the WHO was pretty slow. And at the beginning, again, starting in a regional area, it was not until the 80s that the WHO took a more general focus on health technology. There was a WHO advisory committee on medical research that embarked on a study about modern scientific concepts and methods to human health. And at the same time, the issue of technology transfer became to really get a lot of traction and more interest. So that loomed much larger than this other issue of technology assessment in a budding division of non-communicable diseases and health technology at the WHO. A move from this regional office to headquarters began to make HTA loom a little bit larger, but again, long after the founding of the OTA in 1974 in the US. And here's one quote from the interviews that we did. They, as in the WHO, were not at all involved. It was very difficult to work with the WHO. It took decades before they understood what HTA is. They were stuck in this concept of medical devices, basic laboratories and equipment. And so it's kind of remarkable, right? Because we would expect the WHO and the World Bank to both be promoting this, right, heavily, and yet we didn't see it. Another key informant remarked, we had talked to people at the WHO many times in relation to how are you going to do this? Every country should have at least one person devoted to HTA. It takes a frustratingly long time. A similar story at the World Bank. HTA capacity building was not a major focus of World Bank efforts, even though people involved recognize the strategic value of having the World Bank involved as putting an element of pressure and a route of access to key local decision makers. But it was not until the 2000s, right, 25 years after the OTA founding, that the World Bank began to fund efforts, and those centering in Europe. So implications of this study, and I'll just conclude with this slide. Promotion and spread of an important innovation. This is about promotion and spread of an important innovation, and this relied principally on interested individuals, right? So the founder of OTA in the U.S. did a lot of sort of missionary work in other parts of the world. Also these emerging professional associations. But there was a surprising absence of the WHO and the World Bank during this critical period. And this led to really uneven incomplete institutionalization across regions, whereas CCTs spread pretty evenly and quick. This did not, right? And what's interesting, I think, is to think about this in terms of politics, inequality, and state capacity. Relative to the private sector, pharma, insurers, hospitals, right, in the private sector, state capacity comparatively withered. That's a problem, right, if we care about building more robust UHC programs. And so this was a real concerning thing that I think we can think about and locate in broader discussions about decolonizing global health. All right, thank you.
Hi, everyone. I'll try to keep it short so that we can get to our discussion. So I will start with the they've ruined everything and gone part of the talk, and then I'll come back to the reluctant global health sociologist part at the end. So these two quotations come from two people very differently positioned in the Indian AIDS response. The first is one of the most well-known AIDS activists in India. She was involved in many of the prominent legal cases around sexuality and HIV. And the second is a sex worker activist who spent more than a decade doing peer education at bus stands in the city of Bangalore, where I did my ethnographic fieldwork, and now works at a flower shop on the Bangalore-Mysore highway. So you can see in both of these, they come together in a critique of the HIV/AIDS and the more generally global health apparatus. So the two are taking aim at slightly different types of actors. The first points out the origins of the Indian AIDS response in global health philanthrocapitalism. Here's Bill Gates at one of the community-based organizations where I did field work for this project. This was a $338 million project in India that opened in 2003 and ended in 2012 and kind of continued closing down until 2014. The second quotation here has a little bit of a more ambiguous target of critique. In the context of the broader conversation, the sex worker activist was talking about the global health AIDS apparatus, but more specifically some of the NGOs and activist groups that had sort of changed her life through the AIDS response. But both indicate a kind of resentment toward the temporal frame of AIDS activism and the definition of the AIDS crisis. They're both living in the aftermath of the AIDS crisis, the sort of purported end of AIDS. 40.4 million people have died of AIDS-related illnesses since the start of the pandemic. 76% of people globally are now estimated to be accessing treatment, and new HIV infections have decreased by nearly 60% since 1995. But both of these activists' comments and their lives were shaped by a disease response that had effects far beyond those types of metrics that I just mentioned. The AIDS response in India shone this kind of globally financed spotlight on groups who had previously lived in the shadows of the law: sex workers, sexual minorities, transgender people, and drug users. And both of them in different ways became involved in activist groups that were catalyzed by the AIDS response. Their relationships to the state, to each other, and to themselves were transformed in this process. And then at the end of AIDS, they felt left behind. They point out that even though the donors have declared success and gone home, they're still here. And this was affected in material consequences. So in the aftermath of AIDS, the funding for their organizations was reduced. They had offices closed down. And my book, At Risk, is interested in what happened after that, or what remained after that. So what I want to present in this talk is kind of work that stretches across AIDS, the time in sort of what I call between pandemics, COVID-19. And so I'm kind of talking about my book as well as kind of some research after and sort of moving into a new project that I'm starting on kind of migrant labor, gender, and COVID-19. So I draw attention to the temporality of crisis in all of these projects. In thinking about global health this way, I've been learning from some new scholarship, so critical feminist scholarship on crisis, like global health problems. Many other types of crisis too vary in terms of how acute they are, how chronic they are, how visible they are, how invisible they are. Disasters throw ongoing crises into relief, but for many marginalized people, the crisis has always been there. One example is Luft's work on post-Katrina Louisiana. She develops the concept of racialized disaster patriarchy, which is kind of a twist on Naomi Klein's disaster capitalism. Her interlocutors in Louisiana talk about crisis upon crisis upon crisis. And her larger point is that part of what is disastrous is patriarchy and not just the moment of Hurricane Katrina. Many feminist scholars writing in India about COVID-19 have articulated similar types of critiques. So here are just a kind of couple of mentions of scholars who have done some of this work, kind of looking at COVID-19 and its effect on precarious women workers, particularly domestic workers. So here in one of them, we may survive the coronavirus, but we'll certainly die of hunger. And this is actually a comment that's repeated in many of the kind of civil society reports of migrant workers in the context of COVID, as well as transgender people. So these observations reflect these kind of ongoing patterns of suffering within which disasters play out. At the same time, crises like AIDS and COVID attract heightened attention, right? So some scholars have called this AIDS exceptionalism, right? The exceptional status afforded to certain crises to the detriment of attention to others. So in the introduction to a volume on AIDS that was written and published just as the COVID-19 pandemic began to unfold, so the book came out in 2020, the authors write, by definition, crisis is exception. It is an occasion for judgment, an opportunity to render power, yet a crisis is not meant to last. So built into the logic of crises, and I want to suggest global health responses too, is this contradictory outcome that the response to disaster overshadows other ongoing crises, but then is sort of abruptly forgotten after the crisis is decided to be over. So my first book kind of responded to this literature on the temporality of crisis by situating it within the battleground of civil society. So one of the things I really tried to convey is that the temporality of crisis wasn't just determined by global health institutions, but it was also sort of worked out through the struggles of social movement groups who demanded to expand the definition of what an AIDS response might look like, and eventually built some organizational infrastructures that kind of situated HIV within the larger forms of structural violence that enabled HIV to take root in the first place. So I want to, and this, by the way, is an image of one of the activist groups I studied and write about in the book, holding a protest of some of the AIDS organizations and funders. So this is the kind of fieldwork that's sort of the basis of my book. So in my last kind of few minutes, I want to talk about some kind of fieldwork or interviews I've done in the period after my book came out. And this is a series of interviews that I did with people mostly who I had been part of their organizations and their kind of work while doing ethnographic fieldwork in India in 2012 and 2013, and wasn't able to be in person with during the pandemic lockdowns. And so I did interviews over Zoom Zoom. And this is sort of similar to the caveat that Joe gave about his interviews, that 18 interviews feels like a small number, but these are some of the most prominent activists in the sort of field of HIV prevention in India. So the interviews actually started in 2019, and then in March 2020, we kind of reached out to all the people we had interviewed already, asked to interview them again, and then continued our interviews after that, sort of with COVID-19 in mind. So I did this part of the talk is drawing on a collaborative project with two other scholars, Subhadra Panchanadishwaran and Shubha Chacko. So what I'll talk about now is kind of drawing from more of these interviews with some reference to the ethnographic fieldwork in my first book. So within the political terrain of AIDS activism in India, AIDS had largely become a kind of dirty word. So it signified a biomedical apparatus that must be constantly battled and overtaken, something to always be suspicious of. These are two comments from a collaborator and colleague, Akkai, who's a transgender activist based in Bangalore. And these are two quotations from kind of, the first one is from an interview with her in 2012, and the second is actually from her autobiography, which I helped her write and came out in 2021. So in the first one, and I'll let you read it, she talks about, and this is, she's sort of talking about ongoing HIV interventions. She talks about how HIV institutions sort of refuse to acknowledge the priorities of the transgender community. So she says, you know, the government just keeps dumping money on this community and saying the only thing that matters for you is HIV. But HIV is not the only thing. In this later quotation, she's reflecting on her experience of working as an HIV peer educator. And in this part of her book, she kind of goes on to talk about how while she was doing HIV prevention work, she also used that time to do organizing work around her area of interest, which was rights-based claims. So for many of our interviewees, the kind of terrain of HIV was a complex battleground. The Indian state faced pressure from global institutions to treat it as an exception and differently from other public health problems. But this urgency was also conditional, and it changed as the numbers changed, and particularly when the numbers went down, even though this kind of apparatus had been constructed around the response. And here's another quotation from an activist speaking to this, right, and her realization that all of this is going to be very short-lived. She says, there's a shelf life to a shock. What you can also see toward the end of this quotation is her insistence that this requires, on the part of civil society groups, a certain kind of vigilance, right, that there needs to be an ongoing fight to insist that even after the crisis is over, that there is still attention to the citizenship claims of these groups who had previously been ignored. So most of the people I talked to when I was doing my research on the AIDS response and in these interviews in the kind of post-AIDS era were with people who were professionally funded by and running organization around AIDS, and yet when you talk to them about it, really saw AIDS as kind of low on their list of priorities. And they came from other movements that sort of enabled them to challenge the structures of AIDS organizing. So civil society groups had to kind of rely on their own organizing structures in order to challenge these frameworks and these temporalities. Here's another activist who talks about the short-term orientation of COVID relief programs. And she goes on to say, and later in this interview, that a lot of what these organizations did in their COVID relief programs, partly because the Indian government had increased restrictions on foreign funding for community-based organizations, had to rely on some of the infrastructures they'd built during COVID to turn short-term relief efforts into more long-term work. Here's another similar quotation from another activist, just pointing to the importance of this collective strengthening. I'm kind of moving a little faster just so that we stay on time. But here I just want to note that for this activist, it's really important to position sex work in relation to a broader set of struggles around unorganized work. And that part of the struggle is kind of essential to challenging the more limited temporality of AIDS interventions. Okay, so I'm almost done. Why am I a reluctant global health sociologist? Prerna asked us to kind of reflect on, what are new directions in global health? And when you said that, I was thinking, well, I've always felt really uncomfortable with the label of a global health scholar. I was trained as a political sociologist, as a feminist sociologist, in queer theory, as a student of social movements, maybe globalization, but not necessarily global health. And I think that this has given me a reluctance to take global health institutions at their word and to take the concerns of global health institutions or the temporalities imposed by them as given in the way that I study the boundaries of a social problem. So for my interlocutors, who I've sort of highlighted here, both HIV and COVID are kind of vehicles for their political aspirations, but they don't contain them. And I think that one of the important things that our critical social science scholarship can do to enrich global health is to insist on kind of broadening the temporal landscape of the study of global health problems. In other words, part of our analytical task is not to kind of take it as given where the crisis begins and where the crisis ends, but to connect the short crises to the long crises, maybe the crises of capitalism, the crises of patriarchy, racial violence, to the crises of the macro systems and the crises of everyday life. So I'll end there. I'll just say also this is pretty impressionistic, but there are two articles that kind of lay these out more systematically, these ideas out more systematically. One is an article that just came out in Global Public Health called Between Pandemics. And another is an article that just came out that was co-published with Siri and is on transnational feminist methodologies in global health. So please check those out, and thank you.
Thank you to all of you for your heroic efforts in really giving us such exciting perspectives in such short little chunks of time. So I'm going to immediately open this up to the kind of, again, heroic few who have made it through our lightning talks. And so comments, questions, suggestions. Yeah, and if you could introduce yourself. And sorry, my name is Prerna Singh. I head the graduate program in development, which is the kind of organizing entity for this talk.
Hello. So I have a few questions for several of the researchers. So I
Introduce yourself, please.
well, I wanted to ask first, are we going per researcher, or can I ask all of them at once?
I think you can just ask your questions.
Okay. My name is Betsy Archulus. I'm a fourth year PhD candidate in the history department at Brown. I think I first have a few questions for Dr. Sue. Okay. So I'm curious what you mean by social capital in access to the abortive pills. I'm also interested in why the method of ethnography in for this research, what makes the mode of ethnography most useful in the types of questions you're asking, and then related to that is what types of questions are you asking, when you interview people, or what type of questions are your graduate research assistants directed to ask. And then I'll just give all of them at once, actually. And then I also wanted to ask, I'm sorry, in the plaid shirt, I forget your name. Sorry.
Kevin Croke.
Croke?
Yeah.
Okay, I wanted to ask Dr. Croke, how you're defining low income, why like in, as well as like why these countries, why Africa as the locus of focus for your questions, and like what are the metrics that we're using to define Nigeria as low income, and sort of, I don't like if I understand that, I don't know, like the World Health Organization is using sort of like daily dollar cost of living and defining sort of like income, but like why in your specific project? I guess the sort of, cause like the thought behind my question there is like, I don't know, I study South Korea, and with $8 USD in South Korea, which we don't consider a low income country generally, like the World Bank no longer considers them low income, but like you can buy a lot of things and you can survive on like those $8, versus in the US you can barely get like a meal, right? So if the sort of standard is like, I don't know, like $1 to $2 a day in Nigeria, like what are the sort of like political stakes in using this like as the mode of like measurement, and I guess sort of like how do you engage with that without I'll leave that like more broad-ended. Yeah.
Sure.
And I'm also curious about like the use of the term like clientelism. In truth, I feel like a bit critically about it, because I think that it is a bit like reminiscent of terms like tribalism, which I find are more related to the like colonial aspects of political science, where it like.
Sorry, could I just ask you maybe just to condense your questions a little, if possible?
Yeah.
Yeah, thank you.
Okay, yeah. So like, why clientelism? What makes this distinct from what House representatives are doing? Why do we call it clientelism in Nigeria?
Sure.
But we never use the term in the U.S. And then for I also don't know the name of.
Why don't you ask your question? I'm sure they'll figure out who it is.
Okay. In the presentation, ma'am, on sorry, like the institutional logic presentation, I'm wondering like why James Scott, and sort of because in the historiography there are a lot of critiques on how James Scott is using ideas of institutional logic, and how he applies these metrics of logic across really like broad temporal and spatial realities. So like I'm curious in how you're utilizing that in your research.
Maybe
Great.
we should take one
Yeah.
question at a time.
Yeah.
Can
see,
we?
I have.
Do you have more? Can I ask to return to you if possible? I just want to make sure that if anybody else has a question. Sure. Do you have a last one, or are we done?
I only have a last one.
Okay, that would be great. If you just want to ask your last question, then we can hopefully then get some responses as well.
Yeah, and then like still related to the institutional logic presentation, like where does that institutional logic come from? Like I thought your like critique of the like cultural umbrella as the explanation for everything was like really potent, but then I also wonder like logic itself has a cultural history, and like is itself very much situated in like a specific like cultural and like temporal and like I don't know, like colonial definition. Like so what makes it not cultural? Like what definition of logic like are you thinking about in your work? Yeah.
Great,
sorry,
thank you.
I
No,
know
no,
that
please.
was a
Those were
lot.
really, really thought-provoking questions. Thanks for your very, very close engagement. We're grateful for it.
So maybe we should take all the questions.
Yes,
and
I was
then
going to
if-
suggest that if
yeah.
that's okay with you, is maybe just open it up, collect questions, and then we can have some thoughts. Yeah, Danny, and after Danny, Dan.
So, Professor Su, I have a question about isoprotol. So I had, sorry, my name's Danny Choi. I'm a professor in the political science department. I have a project on abortion access in Zambia. In the process, we interviewed around 150 parliamentarians. And one of the conversations, because abortion is increasingly politicized, there was some concerns among these policymakers that in a way the drug was basically a way to bypass some of the regulations that go into offering abortion access to women, right? So in the Zambian context, you need 3 healthcare providers to actually sign on to receive abortions. Mm-hmm. And some of the more conservative MPs, mostly men, actually voiced their concerns about whether that was a sort of a backdoor way of receiving abortions, bypassing the sort of a legal sort of framework. And I was wondering whether you saw any of that kind of concern voiced in the countries that you were studying.
So thank you, everybody. Those were great presentations. One provocative question that anybody can answer. Kind of lurking behind all the presentations, my name is Dan Smith. I'm professor of anthropology and director of the African Initiative here at Watson Institute. So one question or issue lurking behind all the presentations, most explicitly brought up by Siri when she talked about the effort to decolonize research and the fact that the most difficult institution to deal with in navigating all that was Brandeis, right? In some ways not surprising, I guess. But lurking behind all of this is possibly decolonization as one issue. But it strikes me that across all the papers, all the projects, all the obstacles to effective global health that you've identified are a whole range of things that don't easily fit under decolonization, right? So health technology assessment, I mean, maybe they named it wrong. I mean, it took me 2 minutes to kind of zero in on your presentation, as it often does when we switch speakers, and by the time we got 8 minutes into it, I'm like, health technology assessment, what is that again? And as compared to conditional cash transfers, right? I mean, and with the 3-country presentation, I mean, the differences across those countries, arguably, maybe they are, maybe they aren't, attributable just to the legacies of colonialism. In Britain, all this inequality taking place within the colonial power itself. In Gowri's presentation, temporality, I mean, it seems like the temporality crisis question intersects with the legacies of colonization, but probably will still be there even if we ever address like the legacies of colonialism. So I guess my question is like, how do you think about all these problems that you guys have identified, and which ones fit with a decolonizing agenda and which ones won't be addressed even if we do better with the decolonizing agenda?
Thank you. I have a bunch of questions, but I also know that I have the luxury of more time with all our speakers. So I want to see if, yeah? Great. So if that's okay, maybe we'll turn it back over and go in reverse order. So maybe Gowri, if you wanted to go first, and Siri, we'll end with you.
Sure. So I guess I'll speak to the decolonization questions, and I really appreciate that you identified that as a theme that kind of connects all these presentations. Decolonization is a word that gets thrown around a lot and means a lot of different things to a lot of different people, and I actually see that in our presentations, there are a few different ways that decolonization is operationalized, and one is in the kind of knowledge production process, the kind of work that Siri is doing and collaborating with African universities, and then another is sort of in our epistemological framework, right? How do we identify concepts? How do we define what the problem even is? And then another way, and I think you refer to this as sort of identifying, well, what are the legacies of colonialism and colonial rule in the regulatory landscapes that we're studying? So I can say that in my project, one of the things that's been interesting to think about is that that many of the regulatory aspects of managing crisis in India as a kind of post-colonial country have their roots in colonial regulation. So, and there's a certain cyclicality to that too. So sex workers in particular have kind of been caught up in rounds of regulation and kind of repeated moral panics, each one shaped by the legacies of colonial rule. And so I think part of the decolonizing move might actually be to think about sex workers kind of in a way that does not link them to disease, which I don't fully do because I study them in relation to HIV, but I think that is kind of one of the possibilities of decolonization. But I think all of us need to be thinking about decolonization on all those different registers, to really move the field of global health forward. Yeah, I'll stop there.
Sure. So I'll speak to your question about decolonization as well. I think in my course I teach on the politics of global health. We begin with Reimagining Global Health, a volume edited by Paul Farmer and colleagues. And this really helps acquaint students with the history of global health, how much it is grounded in colonialism, and we start there. And this theme we keep returning to in Metrics, What Counts in Global Health by Vincent Adams, in Sasha White's great new book, Epidemic Orientalism. And I think one of the things that you see in those conversations is the way in which the legacies of colonialism carry through today, right, in global health governance, and the degree in which corporations from the global north are empowered not only to make decisions but to profit in global health. And these inequities that result from both kinds of arrangements. And so there's kind of a through line that these important global health readings draw on. And I think that in my presentation, one of the things that I was trying to get at in drawing that sort of out at the very end is the way in which the inequality in terms of access to this new technology that could help level the playing ground within countries who effectively deploy it is in essence incapacitated, right? Because the WHO, the World Bank, could have done a better job in helping to get the technology into the hands of people who could use it. And thereby, this ended up giving corporations a leg up, right? And so we see the same thing all over again that we did 200, 300 years ago.